So welcome everyone. Welcome to the August 2023 Coast to Coast Prostate Cancer Support Group meeting. My name is Maya and thank you for joining us here today. So the Coast to Coast Prostate Cancer Support Group brings different expert speaker presentations each month on topics ranging from new treatments to side effect management. The group is an initiative of the Prostate Cancer Foundation Canada and its national network of support groups. PCFC support staff include Rochelle Green, Support Services Manager, myself, Maya Quaynor, Support Services Assistant, and Leah Lariviere, our Executive Director. So just some information about us. We are a grassroots nonprofit offering support to patients across Canada. We have many free resources, which include a video library, support group meeting calendar, specialized support groups, and dedicated online forums, local support groups across Canada, brief not kit information packages, one-on-one peer support, and monthly newsletters. For more information about these resources, visit prostatecanada.ca. So just the agenda for today, I'll go over some housekeeping and overview of participation guidelines. Then we'll move into the presentation from Alex Rolland on advancements in prostate cancer treatment and diagnosis. Then we'll move into a moderated Q&A. And then lastly, if time permits, we'll have a support group roundtable discussion. So just the participation guidelines. Due to the number of people participating, we kindly ask attendees to use the raise your hand function on the bottom toolbar if they have a question. People clicking on the emoticon will show up on the top left area of the screen and in the order of when they raise their hand, and then I will call on you during the Q&A. Alternatively, you may type your questions or comments into the chat, and feel free to type these questions in the chat as the presentation goes on, and at the end during the Q&A, we will answer those questions. We also ask that you please keep your mics muted during the presentation and when you're not contributing to the Q&A or discussion. This is the privacy disclaimer. What happens in this group stays in this group. By attending this group, you agree to not share another individual's experiences outside of this group, not to out another patient if you were to happen to see them outside of this group setting, and not to record the meeting in any way. This is the medical advice disclaimer. The support group cannot and does not offer medical advice regarding diagnoses, diagnostics, therapies. Rather, we are encouraged to share about our lived experiences with treatments, side effects, coping, etc., and offer resources to each other. The information provided by the moderators or attendees in these meetings does not supersede the diagnosis or treatments prescribed by your medical oncologist. Please discuss any treatments or interventions with your medical professionals before trying them. To the best of our ability, the moderators or informed participants will attempt to correct any unintentional misinformation. And now I'll introduce Alex. Alex Rolland is a precision oncology expert and chief research director and co-founder of Cancer Treatment Options and Management. Alex is passionate about ensuring that everyone who receives a cancer diagnosis has access to the most effective and least invasive form of treatment possible. With over a decade of experience researching, consulting, and advocating for cancer patients, Alex also works directly with the medical system to explore the newest optimal treatments for his clients. He's an expert in discovering how to optimize your cancer treatment and making this a reality for you. I will now give the floor to Alex.
Hello, everyone. How are you doing? It's a great group. Happy to see everyone here. I think today I had a really difficult time putting this presentation together just because there's so much information since we last met last year, and the advances that just keep coming in. So I'm going to keep it as simple as possible and really stick with my favorite new advances. What I do hope to focus on today is themes, themes in cancer diagnostics and treatment, because I think that's really the best way to understand cancer. When you apply themes to a problem such as cancer, you're able to use insights and developments from many different disciplines, and not just, from prostate cancer itself, but from other types of cancers. So I'm going to share my PowerPoint with you now, and hopefully we'll have some great questions afterwards. Okay, so once again, Cancer 101. Sorry, I'm just going to move this over a bit. What it is, how it forms, how it's traditionally treated, innovations in treatment, and how and why they work so much better than standard care. And really, what is standard care? And so we're going to talk about that. So first off, a little primer on prostate cancer. Basically, prostate cancer, as we know it, is caused by an overexpression of something called the androgen receptor. Now, a receptor, I like to think of a receptor as something that's kind of like the docking bay of a store, or a company, where you have this area where things become shipped in and shipped out. And so really a receptor is something that is used to take things into the cell and that in turn causes changes to the cell. So with the androgen receptor, what happens in prostate cancer is you have too many of them. And the androgen receptor binds something called androgens. And these are testosterone and dihydroxytestosterone. And so that's called DHT. So when androgen binds to androgens, which we call ligands, bind to the androgen receptor, it gives a signal for the androgen receptor to turn on genes that are involved in growth and division of the cell. And when that runs amok, as we know, this is typically called cancer. So once again, the androgen receptor, it's a cell surface receptor, goes both inside and outside of the cell, kind of like a loading dock. And once again, the androgens that bind it and turn it on are called ligands in a basic term. Now, the androgen receptor is a little different than many receptors. It's referred to as a nuclear receptor. And what that means is it actually it resides inside the cell and does not necessarily protrude outside. I know that might sound a little confusing because I call it a cell surface receptor, but that's just how some of these receptors work. And so once again, the ligand, type of molecule, in this case, it's going to be hormones, androgens. They bind onto that receptor. The receptor changes its shape, moves into the nucleus, and then turns on a bunch of what we call androgen response genes. So diagnosing prostate cancer, typically, how is that done? Well, you can have a variety of different symptoms, but typically how it's diagnosed is PSA. Doctors often look at the PSA doubling time. It can be identified through a CT scan or an MRI or even a bone scan. And then typically a biopsy is done where they take a bunch of cores of it and they look at how different it is from a normal prostate cell. And they scale it and they grade it, and then that is called the Gleason scale. So what is PSA? Well, PSA refers to prostate-specific antigen, and what it is it's actually a test for PSA, which is a molecule that is part of semen. It's used to feed the semen during its journey. In trying to reach the egg. It also helps break down the mucous membrane in the vagina, so the sperm can enter and interact with the egg. So it has a variety of different functions. It's not specific to cancer. So prostate cells all produce PSA, and it's not really specific to cancer. What happens is when you do have a bunch of active prostate cells that are growing really fast, they can tend to produce more PSA, and that's why it's used for diagnostics. So I want to talk about imaging too. So I'm sure many of you heard of PSMA PET scan, and a lot of people confuse PSA with PSMA. They're very different. PSA is a secretion of prostate cells. PSMA stands for prostate-specific membrane antigen. And what that refers to is an antigen is something that is on the outside of a cell. So cells typically have a bunch of different antigens on them, many different ones. And these antigens are kind of like a street address. So it tells the immune system exactly what is in that cell. So PSMA will tell the immune system and the rest of the body that this is a prostate cell. And therefore, if it's not in the prostate, then the immune system should have a problem with it. So as you understand, if a prostate cell leaves the prostate, the only reason it can really do that is if it's a cancerous prostate cell. So PSMA is on on the outside of 99% of prostate cells. It's an identifier. So regardless of whether it's cancerous or not, this PSMA molecule should be on the outside of it. So an antigen, in general, refers to anything from basic biology. It's referred to as an antibody generator. So an antigen is something that causes an interaction with the immune system. It tells the immune system something about the cell, or it can create an antibody against it. So antigen stands for antibody generator in the simplest terms. So once again, since prostate cells are only supposed to be localized within the prostate, identification of a prostate cell elsewhere in the body indicates it's probably a cancerous cell metastasis. So the reason we like PSMA scans is what they are is they are an antibody. Well, they used to be an antibody. It's now a small molecule that binds onto PSMA, and it attaches a little bit of radiation to it. And then what they do is they give you a scan. And so this tells us, where all the sites of metastasis are, and it's very, very accurate. The problem with other forms of imaging, such as CT scans or MRIs or, any sort of X-ray, what they do is they tell you that the cell has, or they tell you that an area of the body has different density than the surrounding tissue, but it doesn't tell you that it's a cancer cell. And so it could be many different things. If something is more dense in the surrounding tissue or less dense, it could be a variety of different things. It could be a cyst, it could be, fibrous changes. Most imaging won't tell us that that is, a cancer cell or not. And so what doctors typically do is they will measure the size of a lump and track it over time and do serial scans with the CT. And then if it grows, then they make the assumption that it's a cancer cell. With PSMA, you don't really need to do that. You can get instantly, you can get a test here that scans your body and tells you where these prostate cells are within your body. And therefore, it's very accurate in detecting cancer. One of the limitations of standard imaging is that if a tumor has the same density as the surrounding tissue, in other words, if the tumor cells are spread out a bit and it literally has the same density as surrounding tissue, then any sort of imaging that uses density differences to detect tumors or lumps is not going to detect it. And so because of that, these PSMA PET scans are incredibly accurate. So here's a standard CT scan. As you can see, it's something that most people are going to have a hard time understanding apart from the body and the different aspects here. And here is a PSMA PET scan. And as you can see, it lights up areas of metastasis with a nice little glow like that. The other thing too is the amount of this PSMA fluid that they inject into you prior to the scan. The amount that a specific lump drinks up tells you how aggressive that particular lump is. So not only does it tell you where in the body these lumps are, but it also tells you whether it's aggressive, and it can also tell you whether it's necrotic or not. In other words, when a tumor is dead. So we'll talk about standard care for prostate cancer. So typically that involves this. If it's localized, confined within the prostate, typically that means surgery and possible radiation or brachytherapy, any form to sort of kill the tumor or kill the prostate. Obviously, surgery is best. Getting a tumor out is the best thing. And then brachytherapy is the insertion of little radioactive rods around the prostate to kill it. And then ADT, which stands for androgen deprivation therapy. And I'm sure many of you are familiar with that. So we'll go to the next slide. Okay, wait a second here. So I just want to tell you a bit about some advances now. So as far as ADT goes, most of you are fairly familiar with the shots you get, leuprolide. There is a new version of ADT, And this is a oral medication. It's called Relugolix. It's now being used quite a bit in the States. I haven't seen it in Canada yet, but it's been in the States for a while. And I do know of some Canadians that have actually gotten prescriptions for it and have gone to the States to get it and have brought it back to Canada. So it is available. I think, Health Canada is probably still, trying to balance the justification of cost, especially, with where our things are at with our medical system. But what I think is a good idea is I think everybody who is taking ADT should be bugging their doctors about that and asking for it and requesting it, because that is the way to get it in quicker. So basically, the way this works is it has two benefits over standard ADT. One of the benefits is improved efficacy. So it is able to really result in a high level of castration. And as you know, castration is a term used to determine a lack of hormones, male hormones. And that's very important in prostate cancer, because prostate cancer do use these hormones. So compared with leuprolide, which is a standard ADT, in a recent trial, they showed that 96.7% of men maintain castration through 48 weeks on this new drug, Relugolix, compared to only 88.8% of men receiving leuprolide. Also, it quickly reduces testosterone, much quicker than leuprolide. In this trial, the percentage of patients with castrate levels of testosterone on day 4 was 56% with Relugolix and only 0 leuprolide. So it works much faster. It maintains a higher level of inhibition. And most importantly, it has reduced side effects. So one of the side effects, and this is something that definitely affects a lot of men, but more specifically older men, is major cardiac events. So when you do ADT, it increases your risk of cardiac events significantly. So with Relugolix, it's actually reduced to 2.9% in this study, compared to 6.2% in the leuprolide group. So increased efficacy, it works much quicker, and it also reduces the side effects, the serious cardiovascular side effects. So here's a little slide I wanted to share with you. And it shows Relugolix versus leuprolide. You can see the sustained castration rate is on the left, and you can see how well it worked, 96.7% compared to 88.8%. And here's the reduction in MACE, major adverse cardiovascular events. So as you can see over weeks, while on ADT, the risks of having a major cardiac event do increase. And the blue line up here is leuprolide, as you can see. So at 48 weeks, it's up to it's 5.6% average, but that ranged from 3.5 to 8.9, whereas it's only 2.8% for this new version. So I think it's a great new advancement in ADT. And I think the quicker more people with prostate cancer in Canada ask for it, the quicker we'll get it. So here is another slide. So if you have a history of a cardiovascular event, and many of us do, including myself, then you have a much higher risk of having an additional one with ADT. And as you can see here, I circled this in red. So if you have a history, or if you have a previous cardiac cardiovascular event or a heart attack, then your history then your risks of having another one on ADT is quite high. And so as you can see, it's 17.8% for leuprolide, which is quite a lot. That's reaching 20%, almost 1/5 of people, versus only 3.6 with Relugolix. So if you do have a history of a cardiac event, then definitely this medication is the one for you. And I think this is enough of a reason just to use this medication. Okay, so now we're going to look at some treatment. So typically, once you have metastatic prostate cancer, you can be diagnosed with metastatic prostate cancer, or it could develop over the years. Typically, they start you off with radiation around the pelvic region. And then you'll do what's called an androgen receptor antagonist. And what this is something that binds onto that androgen receptor and hopefully prevents it from signaling. In other words, it kind of interferes with the ability of testosterone and dihydroxytestosterone to bind that androgen receptor and turn it on. So it's kind of like pouring cement down the drain. You know, it plugs it up, and that's how these antagonists work. So right now, there's 4 different antagonists. There's abiraterone, enzalutamide, apalutamide, and a new one called darolutamide. So these drugs bind the androgen receptor, typically at a place called the DNA binding domain, and they prevent it from going to the nucleus. And then, of course, there's also chemotherapy. We'll talk about that in a bit. So androgen receptors, you know, every time I speak with a oncologist, they always have their own preference for androgen receptor antagonists. The problem is that it's really hard to compare them. And to compare them based on studies is not an accurate way of doing things. We don't like to do that in science or medicine because everyone has a different case. Everyone is different. And so you could have a group of patients in one study that's very different from another group of patients in a different study. And so it's pretty hard to compare exactly which one is best. So what I like to do is I like to talk about the mechanisms of how they work. And that can really help us understand which one might be better based on how they work. So the first one is abiraterone. Now, abiraterone actually works in 2 different ways. Not only does it prevent the androgen receptor signaling, but it also inhibits the conversion of testosterone to DHT. And DHT has a 5-fold increased affinity for the androgen receptor compared to testosterone. So inhibiting DHT, that process is pretty important. And then there's enzalutamide, and it has a 5.8-fold increased affinity for the androgen receptor compared to bicalutamide. This has a different mechanism in that it causes senescence, cell cycle arrest, which is an interesting process. And it also potentiates radiation therapy. So then there's apalutamide. This has a 7 to 10-fold greater affinity for the androgen receptor than bicalutamide. It doesn't cause senescence, that cell cycle arrest. And it has slightly less penetration of the central nervous system. So that means that you're going to have less side effects. And anybody who's been on an androgen receptor antagonist knows that they can cause a lot of side effects. And that's because they go into the brain. They can cause brain fog, multitude of problems, even increased risk of strokes. So having a androgen receptor antagonist that has less penetration into the central nervous system can definitely result in reduced side effects. And then there's darolutamide, which is the newest player here. We don't have a lot of data on darolutamide yet, but it was designed for some specific reasons. So it works similar to Enza, but it does not enter the CNS at all. And so that is great because it has the least amount of side effects out of all of the androgen receptor antagonists. It also has the highest affinity for the androgen receptor, and it also causes senescence. But most important, it was designed because what can happen is we can get certain mutations in the androgen receptor. And a mutation is basically what a mutation is it's something in the DNA that encodes for a different product. So the androgen receptor is a a gene actually, and that gene gets converted into a protein that results in the androgen receptor. So what can happen is you can get mutations in the androgen receptor DNA, and that can cause it to change its shape. And therefore, when it does that, then it creates resistance to certain drugs. And in this particular case, sorry, I need to go back here. There are some mutations here that can result in resistance to certain drugs, such as androgen receptor antagonists, such as the F877L and the W742L. What those mutations are is the number or the letter in the front is the designation for the amino acid that is normally supposed to be there. So in this particular case, there's an F amino acid. Amino acids are little building blocks of proteins, and genes encode for amino acids. So genes are basically a string of amino acids put together, and then they create the final product. So in this particular case, at the 877th amino acid, you're supposed to have an F amino acid there, but it's been replaced by an L. And so that's a mutation. And that changes the structure of the gene, of the androgen receptor gene. And the other one is a W. So you're supposed to have a W amino acid there at the 742nd amino acid, and it's been replaced by an L. So in both cases, what this does is it creates resistance to certain androgen receptor antagonists. So they can't bind it. It changes the shape of the androgen receptor, and therefore these drugs can't bind it and inhibit it. So I'm going to give you a slide that goes over the whole process of androgen receptor signaling. So this yellow ball here in the center is a tumor cell. As you can see, you get testosterone from the adrenal glands and the testes, and that enters the cell, and it can go and it can do two different things. It can either directly bind the androgen receptor, or it can get converted through the 5-alpha reductase pathway. And that is the pathway that I mentioned that creates DHT. And as you remember, DHT has a much stronger affinity for the androgen receptor. In other words, it preferentially binds it over testosterone. So I just wanted to show you where these actual androgen receptor antagonists work. And so as you can see at the top, abiraterone inhibits that process, the 5-alpha reductase pathway. And it also binds the androgen receptor, although that's not shown here. And then you could see enzalutamide and apalutamide and darolutamide, they bind the actual androgen receptor and prevent it from going into the nucleus where it turns on the different genes involved with androgen receptors. So I just wanted to show you that abiraterone has a slightly different mechanism than the other ones. Okay, so in precision oncology is really the application of science and defined mechanism to medicine. So you might be surprised to understand that medicine is not necessarily science-based. It uses science as a tool, but it is not rooted in science. And I mean, I have this conversation all the time. I like to say it in this way, is that, 200 years ago, scientists were figuring out the building blocks for the universe, and medical doctors back then were kind of drilling holes in people's heads to let out evil spirits. So science and medicine have not always worked together, and now we're starting to see this marriage of science and medicine. Medicine by default has typically been a statistical approach. And so what I mean by that is, in order to figure out the right drug for a person, and this is important ethically, we want to make sure we focus on treatments. Science is discovery and research. Medicine is the application of that directly to treatment. And so the way doctors figure out what is best for a prostate cancer patient or breast cancer patient is they'll take a bunch of people with the same type of cancer and they'll give them all the same drug, and then they will take the statistics and see how many of those patients responded to that. Those responses are typically broken down into what we call the RECIST criteria, and that stands for the different types of responses. So you can get a You can get a complete response, which is all of the tumors are, in the body respond. You can get a partial response, which is, some of the tumors responded, but others didn't. You can get stable disease, where the tumors didn't grow, but they didn't shrink either. And then you can also have a negative response where the tumors grew. So this is how medicine kind of looks at these. Science and precision oncology is looking at mechanisms and trying to determine how each case should be treated differently. So in cancer or in precision oncology, we like to look at the right drug for the right person at the right time. This is the definition of precision oncology. So the right drug given at the right time for the right person. Those three conditions have to be met for precision oncology. The right drug is obviously a drug that's going to work for that person and work for those genetic features. The right person means that that drug has to be good for that person. It's not going to cause too many side effects. It's going to be effective in that person. The person is going to be able to take that right dose and at the right time. Should the drug be given early in the treatment, or mid-range through the treatment, or later on? And that can make a huge difference. And we're going to talk about that. So when we talk about the right drug, we look at the different mechanisms of the same class of drugs, the androgen receptor antagonists, how they work differently. The right person, that looks at the context of the person's genetics. In other words, the molecular features of one person's tumor compared to another. And basically, we use DNA and RNA testing to look at that. So we'd look at mutations in DNA, and then we would look at expression of genes, which is what we call RNA testing. And then there's the right time. It looks at the timing of the drugs to maximize the synergy. So we're going to focus on the right time. And I want to focus on something that has really been a game changer in prostate cancer. And this is what we call the triplet therapy. So in medicine, we like to treat people with a drug that is good for them, that's not going to cause too many side effects. We don't want to overtreat patients. And one of the tenets of medicine is at least do no harm. So in other words, if you're going to treat a patient, make sure you're not going to be harming them with the treatment. And so therefore, the approach for most diseases in medicine is to, treat based on the symptoms. Don't overtreat. So we're going to talk about why that can be a bit of a problem when you're looking at a disease such as cancer. This was a basic approach. So sorry, let me just back up a bit. Typically, most of you will know that when you go for a prostate cancer treatment, you start on ADT. And if that stops working, then the doctor will prescribe an androgen receptor antagonist. And then if that stops working, then the doctors will use chemotherapy. And after that, they kind of run out of options in standard care. So this sequential usage of these different approaches is the standard way that most cancers are treated. However, when you're dealing with cancer, there's this issue of heterogeneity. And what heterogeneity is something where the different cells and the different cancer cells in the tumors kind of evolve. And they evolve to have their own unique set of mutations. And then different tumors can have different alterations and different mutations, and they can turn on and off different genes. And therefore, not every cancer cell is going to be the same. Now, as a disease progresses, as cancer progresses, this gets worse and worse. So when someone has been on treatment for many, many years, and we look at their tumor cells, we see a huge variation between the individual tumor cells within a tumor and also between different sites in the body of metastasis. And that is called heterogeneity. And it's really a problem with treatment because some drugs will, or some tumors will respond to, some drugs, and then other cancer cells and other tumors may not respond to that because they're driven by different alterations. And so once we have a lot of heterogeneity and variation between the tumor cells, it gets really difficult to treat people. And that's where we have a lot of the treatment resistance. So I'm going to focus on this new theme where we combine ADT, androgen receptor antagonists, and chemotherapy up front. In other words, instead of doing it sequentially, do it all at once. And the goal of this is to reduce heterogeneity. So I'm just going to go over a few studies because I think this is a theme that we really need to understand. Hitting it hard early on is definitely the way to approach cancers. So this is a study where they looked at the combination of one of the androgen receptor antagonists, darolutamide, and they combined it with androgen deprivation therapy and the standard chemotherapy. And this is in hormone-sensitive prostate cancers. So as you can see, the placebo, which is just, whatever that may be, could be a sugar pill, plus ADT and docetaxel. This was the overall survival, the average survival. So whenever you're looking at statistics, we look at three main statistics. Number one is how many people respond out of 100, and that's called the response rate or overall response rate. Then we look at the progression-free survival. And that is a time period when 50% of the patients in a trial have their disease recur after being on the drug. So as you can see, you can cross over from the far left here, and you can see the 50% mark, and you can see where it occurs right here. And they looked at 48 months for the standard care, which is ADT plus docetaxel. And at that point, 48 months, at 50%, 48.9 months, roughly 50% of the patients here in standard care were still or had their disease recur or were still cancer-free. And then up here, it's 62.7% of the patients were still cancer-free. So that's important because it shows right away, adding the chemotherapy early on can really make a difference. And definitely in the overall progression-free survival. Now, it's important to consider this is only 50% of the patients. So they also looked at de novo disease and recurrent disease. And as you can see, in both cases, in de novo disease, which means, you've just been diagnosed, having that darolutamide plus ADT plus docetaxel works much better. This is the yellow line here, in both de novo and recurrent disease. And so that's important. So it's showing that regardless of when you do this, the triplet therapy of this androgen receptor antagonist called darolutamide, ADT, and docetaxel works better than just ADT and docetaxel by itself. So this was a landmark study. It's called the PEACE-1 study, and this really changed things. And so what they did with the PEACE-1 study is they said, well, we've got some patients with some really high-risk features. We know these patients are probably going to have an early recurrence, and we know that typically patients with these features don't do as well on treatment as patients who don't have these features, and they called them high risk. They called it, so we'll get into that. They called it high risk disease in general terms. And so in this particular study, what they said was, let's use this other androgen receptor antagonist, abiraterone. Now you have to combine that with prednisone, and they combined it with androgen deprivation therapy and docetaxel in de novo metastatic and castration-sensitive prostate cancer patients at high risk. So the eligibility criteria for this was they had de novo metastatic castration-sensitive prostate cancer. They had to have distant metastatic lesions by at least one or more lesions on a bone scan or a CT scan. They had to be on ADT, and the study stratified based on a variety of different factors, including, the different sites of metastasis, the type of castration, and whether they'd have docetaxel or not. And so here's the different arms there. They had standard of care plus abiraterone, standard of care plus radiotherapy, and standard of care plus abiraterone and radiotherapy. So As you can see in the overall population, that's the entire study, the red is the triplet combination, and this is a progression-free survival. You can see the ADT plus docetaxel population here. And we'll keep going. And so when they looked at the high-risk patients, which are patients, as they called, high-volume metastatic disease, you could see a significant difference here on the right with the triplet therapy used up front versus the the standard care. However, in the patients with low volume metastatic disease, in other words, the patients that were kind of low risk, there was a benefit, but it still wasn't that clear. As you could see, the lines between the two crossed over a few times. So definitely they found that this was the way to go for people with high volume metastatic disease. In other words, high risk patients. In low risk, over this time period of 5 years, it didn't seem to make that much of a difference right away. Now, of course, you could see as you hit the 5-year mark, you can see there's a divergence of these two lines. So in other words, the red seems to stabilize here at 5 years, and the blue line, which is the standard of care, definitely starts dropping at 5 years. So this was an analysis of abiraterone also, and what they did was they included this with another androgen receptor antagonist, and once again for high risk, but this was non-metastatic prostate cancer. And so as you can see, in this particular case, for the high-risk patients, there was a definite benefit at 108 months. So the theme here I'm trying to outline is a more aggressive treatment early on for patients with high volume disease seems to be a really important theme in these studies. So as you can see here, the standard of care, and then the standard of care plus abiraterone and prednisolone with or without enzalutamide. So that's using 2 androgen receptor antagonists. Sorry. And so now this is a theme that we'd like to look at. So this is all about timing. So rather than doing sequential treatments of ADT, then adding the androgen receptor antagonist, and then adding the chemotherapy, this most recent symposium from 2023, and I want to thank Dr. Neil Love. He did this excellent series on prostate cancer, brought in some of the top prostate cancer specialists in the world. And this is from his symposium in 2023. And what they did was they took an analysis and they said, this whole thing of treating patients aggressively up front with chemotherapy rather than sequentially seems to be a theme. And it seems to be a theme across a bunch of different studies. So as you can see at the bottom is the piece 1. And this is the average overall survival. So in the piece 1, it was 61 months. And once again, this is 50% because it's a medium. It's overall survival, and progression-free survival and overall survival are when 50% of the patients in the trial reach this particular outcome. So 61 months for the piece 1 was when 50% of the patients in the trial had died. Now, some of the patients died earlier, but on average, it was 61 months, and then lots of the patients lived much longer. So when they looked at the different trials, they were able to combine them together. And so on the right, you have the name of the trial, which is a really nice summary. I just love this, this slide because it really shows this theme. And in order to understand these themes, such as the right time, aggressive triplet therapy up front, it's important to look across many different studies. So you can see with ADT alone, and excuse me, this is in high volume metastatic castration sensitive prostate cancer. In the charted and the GTUG 15 and the Stampede, ADT alone was fairly similar, 33 months to 35 months. When you combined docetaxel, chemotherapy to ADT, and this was in the Stampede, the piece 1, the GTUG 15, and the charted, you could see that improved things to, on average, 40 months. When they did add ADT plus abiraterone, once again, if you recall, abiraterone is that androgen receptor antagonist that inhibits the DHT pathway as well as the androgen receptor. In these two studies, the Latitude and the Stampede, you could see the average was about 53 months. But when you combined all three, ADT, docetaxel, and abiraterone, 61 months. And I think this is a real game changer. So what is the justification for this? And so Neil Love and his colleagues came up with this list of justification for doing early chemotherapy and ADT and androgen receptor antagonist early upfront. So they show, recent data from the PEACE-1, the Aronson's, and Enzymet trial shows a consistent overall survival benefit with triplet treatment in men with de novo metastatic castration-sensitive prostate cancer. So why is this triplet so beneficial? Well, it makes sense. The triplet efficiency just makes sense since both androgen receptor antagonists, selective inhibitors, ARSI is the term, androgen receptor selective inhibitors, and taxanes are active after one has failed. So for example, in the COO301, the androgen receptor given post-taxane was beneficial. And in the CARD study, the taxane post-androgen receptor was beneficial. So in other words, both androgen receptors are beneficial after taxanes are not working, and taxanes are beneficial after androgen receptors stop working. So it makes sense. Polytherapy, and this is what we talked about with heterogeneity. This polytherapy targets many of these cells that could go on to have a large amount of heterogeneity. Once again, that's variation between the individual tumor cells and the different tumors in the body. So having this polytherapy up front reduces that heterogeneity, and it results in less prostate cancer or prostate cancer resistant cells. Another point is if the ADT androgen receptor doublet is used for castration-sensitive prostate cancer, then obviously docetaxel will be used anyways once the patients become castration-resistant. So why not use it earlier when it obviously works better and it has less toxicity? So the concept here is, if you're going to use chemotherapy, use it early on in the treatment, not later down. And, this docetaxel has a lot of side effects. So if you're able to tolerate it much better when you're healthier, when your disease has not spread, then obviously that's going to be more beneficial. And if it produces more efficiency and less toxicity, why not use it earlier on? Excuse me. And then they summarized, at the end of the day, 6 cycles of docetaxel are short, and most are well tolerated with G-CSF support in the early stages of treatment. So this is the theme, and this is the paradigm shift, is triplet therapies if you have high disease burden and high-risk cancer. Use them early on, do all 3 right away. What about cases with low volume? So as we saw in that previous PEACE-1 study, the one that really changed everything for us, we saw that, the curves at 5 years anyways, which is what the duration of the study was, didn't really change that much for the low volume cases. In other words, the patients that had the aggressive high volume disease, it made the biggest difference. Whereas, for low volume disease, there wasn't a huge amount of difference. So this is an updated analysis of that. And what they did here is they actually included radiotherapy too. So, that's the triplet plus radiotherapy. So a big problem whenever you're analyzing this, and, many scientists and doctors will tell you, well, how do you make a perfect clinical trial? Well, it's literally impossible to make a perfect clinical trial. And some considerations here that need to be assumed when we're looking at the next slides is that various amendments were implemented during the course of the trial due to evolving standard care of this disease. So as you can see, the trial 2013 to 2018, and it's still being analyzed. So after 2015, docetaxel, which is a chemotherapy, was permitted as part of the standard of care for investigators' discretion and patient consent. And so, in other words, it's tied in with the standard of care. However, after we looked at the Latitude and the Stampede studies, we realized that yes, ADT alone without docetaxel really is unethical. So it became unethical to administer ADT alone. And so docetaxel administration without abiraterone was made mandatory. So standard of care was changed then after Latitude and Stampede. And also, when evaluating the target population of low volume patients specifically, there were similarly no significant differences in the baseline characteristics stratified by recipient of radiotherapy, either yes or no. So importantly, 50% of the patients in the low volume cohort had already received docetaxel. And in this case, the median follow-up was 73 months. So these are things that could, basically be used as an argument against this triplet approach. And I wanted to address these specifically. So here we go. Does this, the big question was initially we thought that this wouldn't work as well. Now, when we look at this, standard of care plus abiraterone plus radiation, and once again, standard of care includes docetaxel and ADT. As you can see, huge differences up here at the top. At 6 years, it's still at 60%. So, median survival in low risk, low volume populations is also really important. So not only does this triplet therapy work for for high burden disease, but once you get past that period of time, you could see in the long run, it actually works much better for low volume disease as well. Okay, so now we're going to move on. So the theme there, combining everything up front really is the way to go, and not doing it sequentially. So now we're going to look at the right drug, targeted therapies, and we're going to look at alterations in the DNA. So the FDA many years ago agreed and approved a specific tumor DNA sequencing test. And tumor DNA sequencing is where you take the actual tumor cells from the biopsy and you look at the genes. Typically, it's a panel of about 300 to about 550, 600 genes now. And you look at alterations in certain genes because now most of the drugs we have target specific DNA alterations. And also, you want to know if you're resistant to certain treatments. If you recall, those mutations in the androgen receptor can cause resistance to certain treatments. And so you want to know what's going on in your DNA. Very important. And the FDA has agreed that literally for every patient, tumor DNA sequencing should be performed in order to make sure not only do you know the right drugs for that person, but you know the drugs that the person is potentially resistant to. And so this is where we're going through the right drug combinations. So a class of drugs called PARP inhibitors. And PARP inhibitors, olaparib is a PARP inhibitor. What PARP inhibitors are, PARP is a pathway where DNA mutations are repaired. And cancer cells do rely on that pathway significantly. So a PARP inhibitor is a drug that inhibits that pathway. So if you have, our tumors are created, or our tumors have, typically all cancers have tumors that have alterations in tumor suppressor genes. And these are typically genes that are involved in repairing damage to DNA. They prevent mutations from happening. And if mutations are occurring that are going to cause cancer, they prevent the cells from copying themselves and growing and dividing. So when we have cancer, what happens is these genes, these DNA repair genes are damaged. One of the most common ones we know of is called BRCA1 and 2. And these genes not only detect damage in DNA, but also are part of a complex of many genes that prevent cells from copying themselves when they do have these mutations that can lead to cancer. So in this study, they use this drug olaparib, and they combine it with abiraterone as a first-line treatment for patients with metastatic castration-resistant prostate cancer. So these patients at diagnosis, or their first treatment, they had become castration resistant, and there wasn't a lot of options for them apart from docetaxel, which doesn't work that well at that stage. Works much better early on. So as you can see, in this particular case, when they tested the patients and they did have damage to their DNA repair genes, and many prostate cancer patients do, they found a 34% risk reduction of progression of death when they combined this olaparib, this PARP inhibitor, plus abiraterone. And olaparib is a fairly easy to access drug. It's been used in breast cancer. It's been used in ovarian cancer. And now we're starting to use it in prostate cancers. And so you can see here the difference here. At 24 months, the probability of being cancer-free at 24 months was 51.4%. 24 months, 51.4% versus only 33.6% with abiraterone alone. So, huge difference there. So definitely PARP inhibitors in this difficult population of patients that are castration resistant is a huge benefit. So in this study, they found that there was a trend towards improved overall survival with the combination, as you can see. Now, the duration of the study, as you can see, the 50% mark was not met in this study. As you can see, both the placebo plus abiraterone and the olaparib plus abiraterone were above the 50% mark. And so that means the median overall survival was not reached. And so as you can see here, NR means not reached, not reached. Excuse me. But we can see a big difference in the amount here. Just what is it? Under 60 here. Yeah, definitely under 60 for the placebo abiraterone, and up over almost above 60, 67 or so percent there. So this is another study where they looked, it's called the magnitude study, and they used a different PARP inhibitor. So they thought, okay, well, if olaparib worked, let's try different PARP inhibitors. So there's many companies making PARP inhibitors. They all work slightly different. They have different mechanisms. But they wanted to look in patients and combine it with abiraterone, first-line therapy. Once again, metastatic castration-resistant prostate cancer. Now, they also looked at patients that had these DNA damage genes altered and who didn't. So they call it, it's called homologous recombination repair. Basically, what that means is that these are a bunch of genes, HRR genes, are genes that use the other template of the DNA. DNA has two, as you know, it's got two sides. It's a process that uses a different template of the DNA to repair it. And so it's a set of genes that does that. So it's a specific mechanism. It's called HRR, and that's all you need to know. So in this particular study, they looked at a variety of patients here. But what they did was they looked at screening for the different HRR genes. And so the different HRR genes, there's a bunch of them, but the ones they used here was BRCA1 and 2. They also looked at ATM. They looked at BRIP1. They looked at CDK12, CHEK2, FANK-A, HDAC, and PALB2. So these are, instead of just looking, so most of the other studies just looked at BRCA1 and BRCA2, but there's a lot of other HRR genes, and not just BRCA1 and 2. So we want to look at all of those genes. So as you can see, they had the patients that didn't have mutations in them and the patients that did have mutations. And they used both niraparib and then placebo. Okay. And so, as you can see, in these patients, all of these different HRR positive cases, the niraparib definitely made a huge difference here. Once again, versus placebo, which is the yellow line below. And then in the BRCA1 and 2 mutated, as you could see, the BRCA1 and 2 mutated definitely work a little better. So if you have BRCA1 or 2 mutations, then these PARP inhibitors are going to work a little better for you than if you have these other alterations in the other genes. But in both cases, a significant difference compared to placebo, as you can see. So then they looked at, they wanted to look at the different alterations once again. And so this is a different way of looking at. And so they looked at patients with response. Now, if you may have recalled, I used something called the RECIST criteria earlier on. This is the different types of responses you can have. And so you have the complete response, which is called a CR, which is where all of the tumors, are taken care of. And a partial response, which is, a lot of the tumors respond, but some are resistant. In late stage cancers, we don't see a lot of complete responses. We see a lot of partial responses and stable diseases. And that's because of that heterogeneity that I described earlier. Not all the tumors are going to be driven by the same mechanism. So if we use a drug that targets a specific mechanism, it's only going to target those ones that have that mechanism. So as you can see, when they looked at the combination, when they looked at all of the HRR genes, they got a significant benefit. 22% had complete responses and 38% had partial responses, compared to placebo, which you can see only 11% and 17% for partial response. And then in the BRCA, the BRCA1 and 2 mutated, it was 18%. So this tells us that not only are these PARP inhibitors good in BRCA1 and 2, but they're also good for patients with other gene alterations in this pathway. Okay, so here's a quick summary, excuse me, recent summary of some different PARP inhibitors trials that are going on and their results. So on the far left, it's the name of the study and the drug they used. Olaparib here is the one PARP inhibitor. And then rucaparib is another PARP inhibitor made by a different company. We have niraparib, and then talazoparib, which is another PARP inhibitor. So, a bunch of different PARP inhibitors all being used at different levels. The patients were different in these groups, but, most of them had previous treatment, 1 to 2 chemotherapy. Taxane is a chemotherapy, docetaxel. And as you can see, most of these studies, patients were heavily pretreated. Now, they also looked at, the HRR status. And so the big question is, okay, well, if it's working in these, or if it's working so well with these patients that have these alterations, would it potentially work in patients that didn't have these alterations as well, just not as well? And so that's the big question that we're trying to answer now. But the point being here, tumor DNA sequencing is FDA approved in the version of the Foundation 1 CDX. And that means that the FDA is saying that if you have prostate cancer, you should probably get treatment, or probably get tumor DNA sequencing. And that way you could tell if these PARP inhibitors are going to be beneficial for you, or if you have mutations in your androgen receptor, will you be resistant to androgen receptor antagonists? So this is where they looked at the benefits, the median overall survival in the genes. So they looked at the BRCA2, the CDK12, ATM, BRCA1, CHEK2, PPR2A, RAD51B, and RAD54L. And so as you can see, obviously, the combination worked the best on BRCA2 altered prostate cancers. And then it also worked quite well for RAD54L mutated prostate cancers, and less beneficial for BRCA1. And then I'm not sure what happened with the RAD51B. I think they didn't have enough patients for that. but definitely you can see the theme here is the type of mutation really helps us determine how well you're going to respond to this combination. And so you have the combination here in the blue and then the standard care in the red. Okay, so May 31st, 2023, so this year, the FDA, Food and Drug Administration, approved olaparib plus abiraterone and prednisone for adult patients with deleterious or suspected deleterious BRCA mutated metastatic castration-resistant prostate cancer, as determined by an FDA-approved companion diagnostic test. So the FDA-approved companion diagnostic test right now is currently the Foundation 1, but there are many wonderful tumor DNA sequencing panels that aren't FDA-approved that work very well. And that's because tumor DNA sequencing has pretty well become standardized. There's a few different companies making machines now, and they pretty well all work very well. So in this case, the FDA has approved the Foundation 1 CDX because Foundation 1 has really put some time and effort into getting that. That was their goal. But there's many great tumor DNA sequencing panels, and lots of hospitals have their own. So the take-home message here is get your tumor DNA sequencing done, because this is an approved combination based on the benefits. Okay, now we're going to talk about the right person. So we're going to talk about immune therapy, and also we're going to talk about this amazing new technology called Theranostics. So typically when you hear of immune therapy, you think of a class of drugs called PD-1 inhibitors. There's also CTLA-4 inhibitors. Just go to the next slide. So PD-1 inhibitors are a class of drugs that inhibit a pathway called PD-1, and that's called programmed death 1. They've been around for about 8 years. We were actually one of the first to ever use a PD-1 inhibitor on a patient. The patient had melanoma at the time, and I was able to convince the doctors and the drug company to provide the drug and the doctors to administer it. The patient had about 4, maybe 5 treatments of this PD-1 inhibitor. They had to pay for it themselves because it wasn't actually, available then. And that patient is still completely cancer-free. So just a short summary of what immune therapy is. So cancer cells hijack the immune system. And they do this in what we believe to be about 12 to 14 different molecular mechanisms. So molecular mechanisms meaning, genetic pathways. So the reason they do that is because immune cells and tumor cells have a lot in common. They use a lot of the same resources, growth factors. So immune cells have to expand their populations very quickly when they detect a foreign invader or a cancer. And they need to do this very quickly in order to, fight infection and so on. So they have these things called growth factors, and cancer cells also like to grow fast. So they like to use these growth factors too. And so what they will do is they will often allow the immune cells to enter the tumor environment, and then they will turn them off. And they have a variety of different pathways they turn them off on. We believe it's 12 to maybe 14. Right now, we have drugs for about 3 or 4 of those pathways. Now that's changing, but when I'm talking commonplace drugs that are available. So the pathways that we have drugs for now are the programmed death 1 pathway, the CTLA-4 pathway, and we now have an IDO pathway drug too. We're going to see a lot more of the drugs for different pathways soon. PD-1 pathway seems to be the most common one in cancers. And it's used early on. So there's many different PD-1 inhibitors. The way I like to describe PD-1 inhibitors is called programmed death 1. So every cell in our body has to have this protein on the outside of it. It's called programmed death 1. And if you don't have that protein on the outside of it, then the immune system cells will see you and they will destroy that particular cell. So PD-1 is very important. Think of it as a kind of a hallway security, a security pass card. Those security pass cards where you swipe them against the door and it unlocks the door. Well, think of every cell as having to have a PD-1 card, and they have to have this card on them or the immune system will attack them. And so basically this PD-1 fits into a receptor on the immune cells, the CD8 positive cells. They're called TILs, tumor infiltrating lymphocytes. They're a cell that goes into the tumor and kills the tumor from the inside out. If you have PD-1, then you just pop it into the receptor on the TIL and it will turn it off and it won't attack you. So what PD-1 inhibitors are is, and so prostate cancers, firstly, they like to produce a lot of this PD-L1. So I'm going to describe this in a very simplistic terms. It's not molecularly accurate, but I think I like this description because it helps us understand. So think of a tumor as having a bubble of this PD-1 around them. So they create a massive amount of this PD-1 around them. And then when an immune cell comes along to investigate the tumor because it's growing too fast, it has all these different mutations, it sees this PD-1, the PD-1 fits into the slot and turns off the immune system. So now we have all of these tumor infiltrating lymphocytes, TILs, that are inside of the tumor, but they're turned off. They're not doing anything to the tumor. They're just turned off. And so the tumor can now steal their growth factors and their resources. So what a PD-1 inhibitor is, it's a molecular sponge, and it inhibits, it basically sponges up all the free-floating PD-1. And so all of a sudden, those tumor-infiltrating lymphocytes inside of the tumor now recognize that they're inside of a tumor because there's no PD-1 to turn them off, and they get activated and they eat the tumor from the inside out. So there's about 12 or 14 of these drugs all approved right now. Atezolizumab is just one of them. It happens to be actually one of the cheapest ones. And so in this particular study, they had metastatic castration-resistant prostate cancer patients. And they thought, these patients don't really have any other treatment options. Let's just try this PD-1 inhibitor. They tried the PD-1 inhibitor and it didn't work. So then they said, well, why doesn't it work? And they found out that there was a bunch of different pathways, a bunch of other cells that interfere with the tumor microenvironment. One of the pathways is called AXL. The other is called tumor-associated macrophages. Then there's also the VEGF pathway. There's a few different pathways that tumors use above and beyond the PD-1. And so, therefore, PD-1 inhibitors don't work in a lot of cancers, like prostate cancers. However, this drug cabozantinib that they combined it with in this trial actually inhibits those other pathways. It's a drug that inhibits tumor-associated macrophages. It inhibits VEGF. It inhibits the AXL signaling pathway. And so it allows atezolizumab to work in tumors that it wouldn't normally work in. And so in this particular, so we call this an immune enhancer. Now we did an educational video on how cabozantinib works. But right now there's about 10 different studies in different tumors that normally don't respond to PD-1 inhibitors. But when they combine it with cabozantinib, then they start responding. And so this is just one of the studies, and it worked quite well. So they expanded it. As you can see, this is the reduction in tumor size. And so the 0 mark is no reduction. Above the line, excuse me, is growth of the tumors, and below the line is reduction. And as you can see, there's a scale of how much it's increased and how much it's reduced. So these are just two different ways of assessing the results. They're pretty similar, 77%. And then in the other study here, this is 70% of 120 patients. So as you could see, there's definitely some really good responses here. And you can see, 80% reduction in some people. And these are all metastatic castration-resistant prostate cancers. So definite benefits here. So this is a slide we've already gone over. Sorry, I'm going to have to skip this one. Okay. Now we're going to get into Theranostics. So I'm sure many of you have heard of Theranostics. Lutetium-177. So what Theranostics is it's we talked about the PSMA PET CT. And so Theranostics is actually a new technology. A lot of Theranostics was actually done in Canada, but also Germany and Australia and other countries. So lutetium-177 is now a new Health Canada approved approach to dealing with prostate cancer. So if you recall the PSMA PET scan that we discussed earlier, when they were doing the early days of this PSMA PET scan, what they noticed is after they would give a prostate cancer patient a PSMA PET scan, they found that often patients had lowered PSA after that. And they thought, well, this is very interesting. Why are patients getting reduced PSA after they have this PSMA PET scan? It's just a scan, it's not a treatment. And so they reasoned that what was happening is that because this PET scan was actually attaching this lutetium to the cells of the prostate cancer via the PSMA binding, or the PSMA, prostate-specific membrane antigen, maybe it was actually reducing the ability of the cells to grow and divide. And so you could see PSMA there. That's that little blue antigen there. It's on the left there, and it's on the outside of the cell. And you can see that this lutetium molecule, this is basically a molecule that attaches and fits into that. So it was initially an antibody, but now they use a small molecule. And so what happens is a small molecule actually delivers this lutetium, this molecule of lutetium, which is a beta emitter. It delivers it and attaches it to the PSMA scan cell, and then the cell takes it in there and it kills the cell. So kind of like a Trojan horse. And we'll go to the next slide. So this was one of the earlier studies. It was on lutetium in prostate cancer. Now, we've actually been using lutetium on prostate cancers for quite some time now. It's very big in Germany, Australia. And so we've been sending patients to Germany and Australia when they run out of treatment options. The beauty of this is if you have high PSMA on the outside of your prostate cancer cells, and most prostate cancer cells have that, then this is a combination that will be very beneficial, regardless of what your genetics are, regardless of what treatments you have. And so this approach, this Theranostics, works in very late stage cancers when all other treatments don't work. As long as you have that PSMA on the outside of your tumor cells, then this treatment will deliver a lethal dose of radiation to each individual cell. So this was one of the original studies in a popular journal. It was lutetium-177 for metastatic castration-resistant prostate cancer. Now, I don't like to include slides because I don't like to include slides on the benefits like I do with the other targeted therapies, because this is not a stratified population of patients, and that's the problem. So, in the other slides, I was able to stratify the patients based on their molecular features or their stage or the grade or the types of treatments they've had. The problem with the Theranostic studies is they're used on anyone who is resistant to treatment, regardless of their genetics. So it's really hard to figure out which patients are going to do best. Now, there are studies right now being done to show which patients they're going to work best on. We've seen patients literally become cured from this. We've seen patients who did well initially and then had to go in for multiple treatments. We've seen a huge amount of variation. So we don't have all the answers yet. But we do know that regardless of where you're at, and if the treatment is not working, then this lutetium will benefit you as a treatment protocol. So you can see based on standard care in this particular study, the standard care alone at the top there, and this was based on imaging, image-based progression-free survival. the amount of tumors and so on. And as you can see, the lutetium greatly outperforms this. And you can see the standard care stopped at 20 months, but the lutetium still kept going, even at 10%, or right after 20 months. Now, when they looked at overall survival, once again, lutetium greatly outperforms the standard of care. And still, 32 months, 20% of patients are still alive, which is pretty incredible for a treatment where we didn't have anything, a few years ago, prior to Theranostics, we didn't have anything. And then here's a study on time to first symptomatic skeletal events. So obviously, the elephant in the room here is, if this works so well in late stage patients, why aren't we using it initially up front? And that's an excellent question. So typically when a clinical trial is done on a new drug, they'll take the sickest and most advanced patients, and that's done for ethical reasons. You don't want to try something new on a patient who has cancer and use them as, as a lab petri dish, for example. You want to make sure that that person has the best available treatment, regardless of what it is. And you don't want to compromise that by giving them an experimental drug. So most of these drugs that are tested on people that are very sick. They have no other options. And so it's like, okay, well, we don't really have any other options. So let's try the drug on you. If the drug works well, then they'll use it. They'll say, well, okay, well, we know it works in very advanced. Let's use it on patients that have had maybe 4 lines of treatment. If it works well on them, then let's use it on earlier patients. And so this progression is a common approach that's used on all drugs. If it works really well in late stage, let's find out the patients that it works well on earlier, and then let's bring it right up to the first potential treatment. So the big question now, and I get this question asked a lot, is does lutetium work much better overall earlier on? And the reality is we just don't have that data yet. But in this particular study, they looked to the time for first symptomatic skeletal events. In other words, did it put off that time period? And as you can see, it definitely did. And sorry, I want to move this here. So you can see here, it significantly reduced it from standard care alone at 6.8 months on average to 11.5 months on average. And then, of course, beyond here. So this is probably a bit of a looking glass into whether we should use this approach earlier on. I suspect we will. It's going to be really dependent on the amount of PSMA molecules a person has, or PSMA on their cells. So if some patients don't have a lot of PSMA on their tumor cells, and therefore this treatment wouldn't work for them. However, if they do have a lot, then it's going to work for them quite well. So I think we need to stratify patients based on the amount of PSMA molecules they have, and that can be determined through a PSMA PET scan. Now, I also have a lot of colleagues in the States and Germany who are actually using and have been using lutetium-177 for quite some time, and they are claiming that it works really well earlier on, in non-metastatic patients or early stage prostate cancers, and they are arguing for it to be done then. The reality is we don't have the data yet, so I can't say that for sure. I highly suspect it will. So I'm just going to go on to the next slide. Oops. Okay. So what do we use beyond lutetium-177? As I mentioned, lutetium-177 is a beta emitter. They also have a new radioactive isotope called actinium-225. This is an alpha emitter. I won't get into the complexities of radiation and the different waves and the different emitters, but the benefits of alpha emitters is that they have a shorter range of distance they can travel. So beta emitters travel, a certain distance, but the alpha emitters don't travel as far. So they're going to have less side effects than the beta emitters. So there's two benefits to that. What that means is, number one, it's not going to have any side effects. Number two, you can increase the amount of the radiation to have more killing effect on the tumors without killing normal cells. So that's a huge benefit. So they can use a stronger dose of radiation on these PSMA binding molecules than they can with a beta emitter. So the data shows now alpha emitters actually can be used after beta emitters stop working. So the studies to show that alpha emitters actually get you more time once lutetium-177 has stopped working. There's also different approaches now, and this has opened up a whole new world of what we call ADT. Sorry, not ADT. It's called conjugates, antibody drug conjugates. So, and what these are, and they were basically designed after this lutetium-177. What we now know is there's a bunch of different molecules on the outside of our tumor cells that may not be on our normal cells. And that's going to differ with every person. And so now we have all of these different drugs that are an antibody that targets a specific cell surface receptor commonly found in a certain cancer. And that then they attach like a chemotherapy drug. So the first use of this was called Bind-014. And what they did was they had that PSMA targeted molecule, and instead of using lutetium, they attached docetaxel to it, and it seemed to work quite well. So right now, the biggest and most advancement, best advancement in cancer treatment right now are these conjugates. And so this is what we're looking at in various cancers. So right now, I believe in the last 2 years or so, the FDA has approved, I think, 14 different conjugates for different types of cancers. And so we now have a RNA expression test that looks at just under 21,000 genes. So we can now look at someone's tumor and determine which one of these conjugates will work for them. The beauty of these conjugates is they will work on any type of cancer, any sort of solid tumor. They're not restricted to a single type of cancer. They will work on, breast cancers, ovarian cancers, prostate cancers. All they require is that you have overexpression of that cell surface protein or receptor, that antigen on the outside of your cells. A common one is called TROP2. I won't get into that now, but TROP2 is found in a lot of breast cancer. And so there's a drug called sacituzumab govitecan. It's a conjugate. And if you have high TROP2 in your breast cancer cells, this sacituzumab govitecan works really well. It delivers a chemotherapy drug to any cell that has this TROP2 receptor. And so we're now finding that TROP2 receptor is also found in prostate cancers. Now, as I said, there's so many new advancements right now. I don't really have time to cover them all, so I want to talk about themes here. And so the theme that I want to talk about with Theranostics and lutetium-177 is just the start of the conversation on ADCs, conjugate drugs. And right now there's about 250, 300 different conjugates in clinical trials. So next year, we're going to be talking about conjugates in prostate cancer because there's going to be a whole lot of new data. However, what we do know now, and we don't really need a lot of studies on this, is we know if you have high expression of a particular surface receptor or antibody that a particular drug targets, a conjugate drug targets, it doesn't matter what type of cancer you have or where the tumors are. This drug will potentially work for you. So little summary based on Neil Love's symposium, because I think really Neil Love is the god of precision oncology. He's just an amazing individual. He doesn't just do one cancer. He brings the best specialists in the world to these think tanks, and then does what's called continuing medical education. This is CME. And so we do a lot of continuing medical education. We attend all of the conferences and all of the cancers that we can. So we're doing it all the time. But in this particular case, this is a nice little slide he put together, or his team put together, from the 2023 continuing medical education. This continuing medical education is what doctors are supposed to do every year. So in this, they summarized all of the treatments. So local disease, surgery, radiation, abiraterone seems to be a really big player, obviously, because it targets the DHT pathway as well as the receptor. Biochemical recurrence, ADT, plus the androgen receptor antagonists, apalutamide, enzalutamide, and darolutamide, the new player that doesn't go into the central nervous system. And then when we have radiographic metastatic disease, castration sensitive, still using combinations, but as you can see, this is where the combinations come in. The apalutamide, enzalutamide, darolutamide, plus docetaxel, or abiraterone, enzalutamide, apalutamide, docetaxel plus abiraterone up front plus ADT, the PEACE study. And then the other approaches of using docetaxel plus darolutamide. And as we saw this year, it is not just restricted to patients with high risk and high burden disease. It's actually beneficial in patients with low burden disease. It's just that we didn't have the long-term data to see that yet. And patients with low burden disease typically don't have a recurrence in the first 5 years. So as a consequence, we haven't seen that data yet. Now we're seeing it. So triplet therapy is the big theme here. And then you can see here, as you progress, you go through docetaxel, abiraterone, enzalutamide. I didn't talk about sipuleucel-T. You can see cabazitaxel. It's a new chemotherapy drug. Radium-223, that is available in Canada. Radium-223 is very beneficial for bone-only metastasis. It's not that beneficial for lymph nodes or tumors in other areas of the body, but it is beneficial for tumors in the bone. And then, of course, you can see the new player, lutetium 177. And then castration resistance here, we can see that the PARP inhibitors and even immune therapy, pembrolizumab, is a player now. So really, the secret here is, the themes I see here is, number one, tumor DNA sequencing. Number two, RNA expression testing to determine whether any of these new conjugates could be a benefit for the person. Looking at those cell surface receptors. There's at least 14 we can look at now, and there's a bunch of other ones. Literally every day we find a new conjugate drug target in clinical trials that's showing benefit, and we add that to our list of what we look for. And then, of course, you want to know your HRR status, so, whether these PARP inhibitors will work for you. And you want to make sure you know whether you have any androgen receptor mutations or other mutations that can create resistance to apalutamide and enzalutamide and darolutamide and abiraterone. You want to know that up front. You don't want to spend time on a drug that's not going to benefit you. So, for example, if you find out you have an androgen receptor mutation, then it would be better to use a drug that is designed to target that mutation. And if there isn't one available, then it might be better to skip straight to lutetium rather than wasting time on a drug that you know is not going to work for you. So really, I really can't emphasize this enough, is really spend the time on your diagnostics. Get the tumor DNA sequencing. If you can afford it, get the RNA expression testing. Really look into these things because it can determine so much of what is available. Okay, so what have we learned? The current standard treatment is not all there is, and I like to say this in this way: the future is here now. It's just not well distributed. So when I hear a doctor say, "Oh, this is current standard of care," my next question is, current standard of care where? At your hospital, at the hospital down the street, at MD Anderson, at one of the large European hospitals. It's never possible to have a standard of care across all facilities. In Canada, we have standard of care that is somewhat similar. And this occurred many, many years ago when hospitals in downtown Toronto were just having an influx of incredible treatment options, and patients who were getting treated in rural Saskatchewan, farmers and so on, were getting treated in a little trailer. They didn't have access to scans or any of these things that people in downtown Toronto did. So there was an effort to make that across the board, that every person in Canada gets access to these treatments. Unfortunately, rather than bringing up that little medical trailer in rural Saskatchewan to the level of the hospital in Toronto, what they did was they reduced funding to those major hospitals and provided that to Saskatchewan. So while this is great to have a standard of care that every Canadian can get, it definitely reduced the benefits of treatment. And we had to totally cut back on some of the advanced treatments in order to allow all Canadians to get the same level of treatment. That's not our problem. Our initial issue when we have cancer is to get the best possible treatment we can. It's not what someone else is getting. And while your doctor is not going to feel comfortable, obviously, they want to see everyone getting the same standard of care. It's not their job to ensure that you get the newest and the best. It's their job to make sure you get the same as all their other patients. And when you have a unique situation, you have unique mutations, that falls on you as an individual to do those diagnostics, to find out what's best for you, to use these new data to see whether a certain treatment is going to be best for you, and then to go to the medical professionals or provide that information to your doctor and say, well, I have an androgen receptor mutation here clearly, and you can see here that these drugs aren't going to work for me. Or I would like to go in lutetium right away, because I have high PSMA. So what I want to show here today is that targeted therapies and immunotherapies provide statistically important longer life and better quality of life during and after treatment, and they can result in a much longer time of cancer-free durations and lower recurrence rates and more complete remission than what may be considered standard care. Now, if it's FDA approved, it's standard care. But as I mentioned, many of the things we talked about today are FDA approved, if not all of them, but they're not here yet. And that's because, as I mentioned, the future is here now. It's just not well distributed. And, I like to say this when people say, well, why is that the case? Well, we can't even get clean drinking water to all Canadians. My GP says, hey, why are we doing all this money for cancer treatment when we can't even get clean drinking water for Canadians? Let's do that. That's going to have a bigger impact than getting advanced new treatments. I agree, but I don't work for I don't work for the water company. I work for cancer treatments. And I would like to bring the best new treatments to people with cancer. So this is a very interesting slide from a recent study. And I think this really sums up the problem we're dealing with. And I think it's important when you want to address an issue, you need to understand the problem at the heart of it. I think standardized care for all Canadians, while that is a wonderful thing, it's resulted in many hospitals losing their budget, so they couldn't do advanced new treatments. And so, it's kind of it's a dulling of science in a way. So aside from significant factors like budget limitations, which is huge in Canada, high caseloads, which is huge in Canada, and staffing concerns, the main issue is a lack of education for physicians. And, as I mentioned, 150 years ago, physicians were actually drilling holes in patients' heads to release evil spirits, while, Madame Curie was figuring out the building blocks of the universe. So a physician's training and their job is typically emergency medicine. They don't have any DNA knowledge, most of them. And even if they are a specialist oncologist, it's unlikely they're going to have a deep level of genetics and understanding and how it impacts their treatment. And that's not their job. It's not their training, and it's not their job. Unfortunately, we have this huge disparaging difference and gap between science, what is available, and treatment. And so I like to see treatment and medicine as the industry and science as the research. We need to have this gap brought together. And that's going to require a lot of different disciplines, not just one. It's going to require a lot of people understanding the science and communicating it and applying it in a manner that deals with budget limitations and high caseloads and staffing concerns. And so right now, I believe the approach is to do it one patient at a time, from a bottoms-up approach, rather than taking a group of patients and say, how can we best treat this group of 50 patients? Let's look at each patient individually. Unfortunately, that's up to us to do. And so that requires we get tumor DNA sequencing and RNA expression testing out of pocket. So one of the limitations, obviously, here with doctors is it was a study that looked at the implementation of precision medicine by surveying physicians working in large academic medical centers. So these are academic medical centers. In other words, not just your standard hospital, but a hospital that has a full research and academic department. And I can assure you right there, there's not a lot of communication between patient treatment and research. I've witnessed that myself in my scientific career. So in this particular study, they assessed prior training in genetics, use of genetic testing in the clinic, which we call bench to bedside, desire for additional resources in genetics and genomic medicine, and perceived barriers to successful integration of precision medicine, such as, if you have a DNA repair mutation, should you get a PARP inhibitor. Only 20% of the respondents reported moderate or extensive training in genetics. Physicians with limited or no training in genetics were less likely to have ordered a genetic test for any purpose. Furthermore, 41% of physicians responded that their lack of training identifying appropriate genetic tests and how to interpret the genetic testing results was the most significant barrier to ordering genetic testing for their patients. I don't know why we as a society is dumping this on physicians. Physicians are experts in treating patients. Why should they be tasked with trying to understand how and what drugs to use? That's just such a different discipline. We need to let the doctors do what they do best. And that's to make sure that we're not getting too much of the drug, to make sure that the drug is not damaging our organs, and to make sure we're getting treated when we should and we're getting the scans when we should. Understanding the science behind it is not part of what they are trained in, and it should not be dumped on their doorstep. We need a discipline that connects the two. Okay, so just a summary of what we've looked at, the 4 pillars of precision oncology. Regardless of the type of cancer you've been diagnosed with, your current stage, success lies in personalized oncogenomics, making sure you are using the 4 pillars of precision oncology. And in this case, precision diagnostics means getting testing of tumor DNA and RNA. If you have prostate cancer, get a PSMA PET scan. Getting some personalized research done, targeted therapy treatment plans, and precision treatment monitoring. So here's a summary slide of the different aspects and things that we do in CTOAM. We have our first pillar, which is genetic testing, tumor DNA testing, RNA expression testing, inherited mutation testing, precision imaging, PSMA PET, MRI, pre-nuvo MRI, which is a new MRI for detecting cancer. Personalized research, that's getting a second opinion consultation. So the first is information gathering. The second is information analysis, treatment advocacy, treatment option review, self-advocacy training programs. We have a wonderful educational program, self-advocacy training program now that we've just gone online with. It's a great program. I'm sure Michelle could talk more about that. And then, of course, personalized oncogenomics programs, targeted therapies, and then treatment monitoring, finding out what's best.
Thank you, everyone, for coming. And of course, thank you, Alex and Michelle,